We have always yearned to explore, to be revolutionary in seeking innovative ways to improve human life. We are uncompromising in our academic rigor, in our dedication to propel medicine forward, in our quest for quality and excellence, and in our journey to keep answering the next what if. It's not just something we say, it's in the very DNA of who we are. We are VCU Health. We believe healthcare is about doing, the research, the homework, the hard work. It's about tenaciously exploring the most exceptional ways to improve the health, recovery, and lives of others. The very soul of VCU Health is built on decades of pushing ourselves to forever ask more on behalf of our community and our patients. From our very first years to our most recent advancements, we are driven to learn more, dig deeper, teach passionately, and never rest in order to be a true leader in discovering what's possible in health and recovery. We are teachers and visionaries, pioneers and problem solvers, relentless researchers, and compassionate caregivers. We turn brain power into people power. United as VCU Health, we will build on our history of innovation and unprecedented care, and continue to pursue new paths forward as one of the top medical research institutions in the U.S. and a premier integrated health system. And we will be forever passionate and tireless in our unyielding pursuit of discovery.
I remember Dr. Fisher standing at the foot of the bed and saying, "Fact is, Mr. Bradshaw, if I don't get you a liver in a week, you'll be dead."
I've coached for 40 years. You're battling an opponent. You're trying to defeat that opponent. You know, when you're coaching, that opponent's pretty insignificant. When it's your life, the opponent's pretty daunting.
It was just going to happen. Nothing specific that I can say there except I just felt it and I knew I had to believe. But the folks here, everyone who works here, the gazillions of people that it must be to run this place have been wonderful, wonderful to a person.
If it breaks some ground somewhere where the next time surgeons have confidence that they can do this kind of surgery, just transplantation, and have more confidence that they can transplant an older liver, then I will maybe serve some purpose on earth that I didn't see.
Good evening. I'm Margaret Ann Bollmeyer. I'm the president of MCV Foundation, and I want to welcome you to the 8th Discovery Series event in Williamsburg. Thank you so much for coming out tonight. We have a wonderful program planned for you, and I think you've just seen what I might call an introduction or a preview of that. We started the Discovery Series in 2013, about 3 years ago, to try to communicate to the Williamsburg community some of the excellent work that's happening at VCU Medical Center and Massey Cancer Center on the MCV campus at VCU. And tonight we'll hear about a different topic, something new. So tonight's topic, I think you saw the title, Tune-Up, Cleanup, and Spare Parts, Advances in Restorative or Restorative Medicine. So I think that we have a very interesting evening in store. I want to, just as a welcoming part, I want to introduce a number of MCV Foundation trustees who are here tonight. And so if I call your name, if you'll just stand or wave, please. Roger Beauvais and his wife Ann are here. Nice to see you. George Burke and his wife Lyons in this room. Dr. Charles Caravati and his wife Betty. Charles Crone and his wife Jenny, Gail Johnson and her husband Charles Earl, Becky Perdue, Harry Tallheimer, our board chair. Harry's over under the light. I can barely see him because of the light. And Judy Woods from this community as well. So thank you all for joining us tonight. The MCV Foundation was founded in 1949 to support and garner and steward support for the MCV campus. And that remains our mission today, to inspire and steward philanthropy to support the MCV campus, to help provide additional funding for the kind of research that we'll hear about tonight, the clinical care that we'll hear about tonight, and the education that happens in the 5 schools at VCU, the 5 health science schools. So before we get started, I also want to recognize the host committee that came, people from the community here in Williamsburg that came together to help us really create and plan this series, and has continued to help guide our decisions around topics and events for the Discovery Series and the Discovery Society. So the members of the host committee, Julie Baxter and Paul Dresser, I know that you're here tonight. Thank you. Louise and Bob Canfield. I know I saw Louise earlier tonight. Hi, Louise. Ginny and Charles Crone. Back there, thank you. Jane and Jim Kaplan here. And Judy Forehand Woods. Thank you all so much. And please join me in thanking them. So at this time, I'm going to ask Judy to come forward and make a few remarks.
Thank you, Margaret Ann, and good evening. It's wonderful to see so many friends in the audience this evening. On behalf of the Discovery Series Host Committee, we add our words of welcome. After, as Margaret Ann said, we initiated the Williamsburg Discovery Series, it was to bring information about the excellent health care available in the MCV Campus and VCU Health. But a number of individuals said they wanted more. So last November, we launched the Discovery Society. Members of the Discovery Society share a commitment to supporting excellence in medical research and patient care. Discovery Society members contribute $1,000 or more annually to the MCV Foundation in support of the medical center and its units or programs, such as Massey Cancer Center, Pauley Heart Center, neurosciences, or any of many, many specialties. Annual contributions from Discovery Society members are tax deductible, and 100% is given to the unit or specialty that you select, 100%. We currently have 75 members in the Discovery Society, and we are very grateful to those who have joined us. You see the These are incredible, wonderful supporters. You will see Society members also with ribbons on their name tags, and some are sporting new pins that they've received tonight. Society members are invited to special events on the MCV campus, such as the opening of the new 640,000 square foot Children's Pavilion. This $200 million facility is the most advanced pediatric outpatient center in Central Virginia. And we also did a behind-the-scenes tour of also a state-of-the-art Now Center, Neuroscience, Orthopaedic, and Wellness Center for orthopedic and neurological conditions. We further have a nice time with receptions, including a sneak peek of the Botticelli exhibit at the Muscarelli, which will be held in February, or smaller luncheons with programs on specific health topics. Members receive a great deal of information while supporting a great cause. We invite you and hope that you will join us. As you leave this evening, members of the Foundation staff will have packets of information on our bios of our wonderful physician researchers, as well as information on the Discovery Society. Again, we hope you will join us, and please enjoy your evening. Thank you.
Thank you so much, Judy. So now it's my pleasure to introduce our facilitator for the evening, and I want to say I'm not sure if that's really the right word, because it seems like a word that doesn't encompass everything that Jerry Strauss is doing for us through this Discovery Series. Jerry is the Dean of the VCU School of Medicine, and many of you know that he's been part of this Discovery Series from the very beginning. He helped us create the program, and he has the format for the program, and he has continued to be the person recruiting all of the physicians and faculty and administrators who have participated in Discovery Series events, and really taking the time to think through how do we communicate to an audience what we're doing at VCU in only an hour. How do we do that? And he does such a beautiful job with it. And although I've mentioned he announced that he is retiring soon. Fortunately, he agreed not to leave before someone else was in place. He has agreed that even though he is retiring from his position as dean, he will not retire from his position as heading up this Discovery Series program. Dr. Strauss joined VCU in 2005 as the 23rd Dean of the School of Medicine. Under his leadership, the School of Medicine has raised more than $352 million. The McLaughlin Medical Center for Education opened in 2013 under Jerry's leadership. Dean Strauss has authored over 300 original scientific articles, and he holds 12 patents. Last year, VCU's research enterprise hit an all-time high of more than $270 million, with the medical school representing more than half of that. Please join me in welcoming Dean Strauss.
Good evening, and thank you, our Williamsburg friends, for coming out this evening for our 8th Discovery Series session. I want to particularly thank the host committee and the Discovery Society, who have been so helpful for us in terms of crafting these programs, and indeed, much of the content that we present represents what you want to hear, and we hope to continue that in the future. Tonight we have a very interesting topic that I think will tickle your imagination, because it's about the future and what is actually happening today in real time at the VCU Medical Center. So even though I'm being blinded by these lights, I would like to ask the audience a question. Does the name Steve Austin ring a bell? Jamie Summers. Yeah, the $6 million man and the bionic woman. Yeah, good for you. You were listening. You were there. So yeah, you were watching TV. So it's 1974, and this concept of bionics and restorative medicine, because as you know, Steve Austin had been in a serious accident and he had been reconstructed with bionic devices. And this was at a time when transplant surgery, solid organ transplant surgery, was just becoming really routine, when total joint replacement was just at the cusp of routine clinical care. And so the creators of the $6 million man were forsaging the future of restorative medicine. Quite remarkable. Now, I had to do the calculation. So what is the $6 million man worth today in 2016? $30,717,532. But I actually worked on Wikipedia and discovered that there are medical economics people who actually try to figure out what the true cost of creating the $6 million man is, and it actually calculated out to more than $100 million. And any of you who have tried to decipher your medical bills, particularly if you were an inpatient, will clearly understand that the $100 million figure is correct. Anyway, what I've decided to do is to pick some of my very distinguished colleagues who work in the area broadly of restorative medicine to give you some insight into their particular areas of expertise, what they're doing today, but also to talk about the future, where we're heading, what's the next great advance that will restore health, either by stimulating the regenerative properties of our body, and this is a very important concept, or actually replacing with artificial parts, if you will, organs that need to be replaced. So I'm going to call and introduce my colleagues, and they'll come up on the stage. And the first individual is Dr. Stephen Cates, who's professor and chairman in the Department of Orthopaedic Surgery. Steve? Dr. John McCarty, who's professor of Hematology-Oncology, and he's medical director of the Bone Marrow Transplant Program at the VCU Medical Center, which is the largest bone marrow transplant program in the Commonwealth of Virginia. Dr. Phan, who's associate professor in the Division of Surgical Oncology, an expert in cancer immunotherapy. Dr. Trevor Reichman, Associate Professor of Surgery, Director of the Pediatric Liver Transplantation Program, and Director of the Living Donor Liver Transplantation Program. Part of the Hume Lee Transplantation Center, which was one of the founding centers for solid organ transplantation. And last, my good colleague, Dr. Leland Rogers, Professor of Radiation Oncology. So, Dr. Cates told me a few weeks ago something that was music to my ears. He says, 70 is the new 50. And I was happy to hear that because I'm going to be 70 next year. He's an expert in joint replacement and hip fractures, and I wanted him to give you some insight about the process of total joint replacement, who should have it, who shouldn't have it, and what can you do after you've had your joints replaced. Steve?
Well, joint replacement is a growing procedure, and I think back in the days of Steve Austin, it was experimental. It was just getting started in the United States. But now it's commonplace, and it's getting done younger and younger. But joint replacement is basically a procedure that we can restore the function of joints, bad shoulder, knee, hip, even ankle. So elbow, all these joints can be replaced, and by doing so, it enables us to regain or retain function that we had previously lost. So how many of you have had joint replacements already? So, okay. So, you know, it's an amazing thing to see because you can all, I'm sure, attest to the fact that beforehand, things are tough. Afterwards, you can sort of get back on with life and do the things that you used to be able to do and want to be able to do, whether it's playing golf or going shopping or whatever whatever you would like to do. So these things are, you know, they're vital functions that we want to do. So joint replacement is an activity enhancing surgery or restoring surgery. So to have it done, you want to be healthy as you can be, because having this elective surgery is all about mitigating risk or lessening your risk. So getting your medical conditions under control, your diabetes, if you have it, under control, hemoglobin A1C should be kept low, and making sure that your physician checks you out and makes sure that you're a good good candidate for surgery. Having the surgery done by someone who's proficient in it and efficient with it in a good system is very important. The system of care makes a difference. It's all about the whole system. If you think about having it done, it's probably best to not wait until you're really debilitated with the problem. It's best to have it done while you're still active so that you can remain active and have a good outcome. The surgery is probably easier recovery for the hip than it is for the knee. Again, the shoulder is sort of somewhere in between. Sometimes with the shoulder surgery, it's a little bit tougher recovery, and there's only a few surgeons who are really good at that particular operation. We fortunately have one of them at VCU. Who's really a wizard at that operation. So this is it's a surgery that's I think many of us will have, many of us have had. It's funny to see even my own mother had it done. Of course, she didn't tell me she was going to have it done until after it was done. So she stayed one day in rehab and then went home, and now is probably in better shape than I am. She works out 3 hours a day and lives in a senior community in Boca Raton. So you know, this is that's a success story. But you know, this is really it's a life-restoring surgery and life-preserving surgery in many ways. We're starting to do the joint replacements for patients with fractures as well, so that they can get mobilized right away. So for some hip fractures, total hip replacement, or knee fractures. Yesterday I did a lady who had a broken tibia and replaced her knee so that she can get up and walk today, and instead of having to be down in a wheelchair for 3 months. So this sort of thing is a restoring surgery as well.
Steve, thanks. John, you're one of the pioneers of bone marrow transplant therapy, and it was one of the first, I think, cell-based therapies that was introduced into routine clinical care. So I wonder whether you could just give us a thumbnail sketch of the process, but more importantly about the future of bone marrow transplantation, and particularly the ability to use it beyond the current domains of bone marrow transplant therapy.
Sure. Jerry's giving me a lot of credit for being one of the pioneers. I trained
with a Nobel laureate.
Trained under them, definitely. In fact, I've been doing bone marrow transplant since I was an intern back in 1980, back in the mid-'80s. And one of my mentors went to Seattle and there learned how to do bone marrow transplantation under the man who eventually won the Nobel Prize in 1990 for bone marrow transplantation, E. Donald Thomas. And learned a lot. I'm fortunate to have a lot of very positive mentors. Now at the time, bone marrow transplant was a very different thing than it is now. It was, I'm going to use a football term, the Hail Mary pass of medicine. It was the last-ditch effort. It was, we don't have any other treatments. This leukemia, this disease is far, far, far too resistant to any of our standard therapies, so tell you what we're going to do. We're going to take chemotherapy and radiation, we're going to escalate it to about 30 to 35 times more potent than what your doctor can give safely in the hospital. And then we're going to give you back a new bone marrow that doesn't have the disease in it. Replace the bone marrow that gets injured by the high-dose therapy. And it was not a very pretty thing to see. Many of these people had been through multiple rounds of therapy and had really been worn down from that. You can imagine how people would feel after they'd been through their 3rd or 4th rounds of different kinds of chemotherapy. But there was success, and there was some elegance in what we started to see. And so from that rather troubled toddlerhood, moving it into where we've been able to refine it, to where we're actually, instead of having just 2 different ways of doing it, we started to learn that the immune system is actually the thing we should be harnessing. Let's not punish the cancer. Instead, let's do enough to control it, but let's make the immune system part of our armamentarium of tools. And we're getting better and better at doing that. In bone marrow transplant terms, it means let's not just replace the bone marrow, let's replace the immune system. And let's keep it directed at not rejecting organs like we worry about with solid organ transplantation. But let's have it reject the cancer. And as we've learned more from the Genome Project, from advances in biology about immunology, advances in biology about cancers themselves, we're learning that we have to replace the immune system. We have to rejuvenate the immune system. We have to enhance or de-exhaust the immune system so it does a better job of not just eliminating the cancer, but providing an ongoing sentinel guard dog, if you will, over the long term to keep that cancer from coming back. We're now getting to the point where better understanding of how to support patients, how to understand who's best going to benefit, that our largest growing population of people going through bone marrow transplant are aged 60 to 78. Now, I secretly believe it's because as I grow older, I want to have options, okay? And in fact, when I was an intern, if I came as my age now to me as a patient, I would have been too old for a bone marrow transplant at that time. I'm in my mid-50s. So now we're treating patients up to their mid-70s because now we are doing tailored medicine. We're doing individualized medicine. We're tailoring the treatments and the manipulation of the immune system to not just the disease, but to the patient and any other medical issues they may bring with them that need to be accommodated for. And that's why we're able to offer this life-sustaining and life-saving treatment to more and more and more people. Now, I took over the bone marrow transplant program I came to Richmond in 1996 from Seattle. Took over the program in 2000. At that time, we were doing about 50 transplants. Most of them were a fairly simple kind of transplant. Today, because of the support from the institution, because my team having really great interest in looking at how to focus and adjust the immune system, we're taking what was really trying to do surgery with a butter knife. Now we're down to we're using not just a scalpel, we're trying to use a laser. And so we're learning on how not just to take an immune system that a patient gives us or a donor gives us. We're now taking those cells and changing them. So if I use another analogy, if the old version of transplant that we were doing even 5 or 10 years ago was as though release the foxhounds to go look after the quarry. Okay, it's a whole bunch of them, and they're all just looking non-specifically. What we're now getting to is we're actually giving the bloodhound the scent, and that immune system can go after that one particular scent and only attack that particular area. That's our gold standard. We've still got some kinks to work out of that, but that's something that we want to do. And this may actually make it possible to use bone marrow transplantation to not just tailor for safety, but to tailor for specific functions. We just recently had a conversation, we were talking about this earlier. There may be a role of trying to use this for treating things like autoimmune disease, multiple sclerosis. Replace the immune system that has the wrong idea of what is self and what isn't. We have the opportunity to do what's called gene therapy, replace a disease where a gene may be altered, like sickle cell. And so we have a trial now where people with high-risk sickle cell, they're having complications, up to age 30 to 35, may be able to be cured of their sickle cell because we're giving them a bone marrow that doesn't have the sickle gene. And so that's where the power of this potential technology is at least starting to come to. I would say that we're in our mid-20s. We still have some maturity left to go, and that future is very exciting. And I'm very excited to be part of it. I'm very excited about the process that Jerry has started and the institution has started, VCU, and the team that they've built for us to move forward. We may even be able to allow some of the solid transplant patients, this is down the road a while, to come off immunosuppression. If we can use transplant to induce tolerance so that a transplanted organ isn't seen as foreign. That way, no more immunosuppression, no more lifelong risk of infection, no more care. Not just surviving, but thriving, and that's the goal.
Yeah, I cannot emphasize enough what John has just said about the stellar advances in the field of therapeutic immunology. I actually thought the Nobel Prize in Medicine and Physiology would have been given to a researcher who works in this area. I suspect it will happen next year. But he told you several important things that have really changed the treatment options for patients. You know, like 70 is the new 50. It is for bone marrow transplantation, because years ago, patients over 50, in their 50s, were not candidates. They couldn't stand up to the rigor of the bone marrow ablation and then the transplantation process. But what's going on right now for both adults and pediatrics in this field is absolutely game-changing in terms of therapies for diseases which would absolutely universally fatal. And we do 200 bone marrow transplantations a year, something like that.
We're in the top 20% largest transplant program in the country.
Yeah. So you go to the place where they do a lot of them, and they do it right. And John's got the great program. And it's a great segue to Dr. Phan, who is the surgeon that John talked about, but she uses immunotherapy in the treatment of melanoma and other cancers. And why don't you just follow up on John's comments about the role of immunotherapy in cancer treatment?
Yeah, so for what Dr. McCarty mentioned of bone marrow transplant being in the, let's say, 20s, you know, for blood cancers and lymphoma and things, you know, solid organ cancer, solid cancers has been, you know, unfortunately have not had much of a great success with immunotherapy until very recently. So as someone who actually started working on this since 1999, it's amazing to me how much things have changed. So just to give you a background, you know, I'm a surgical oncologist, and usually people have like, surgical oncologist, well, what are you doing immunotherapy? Part of it is because when I initially was a surgical fellow, I decided to get some research experience, and I got research under my mentor there, who happened to be at NIH, who was a surgeon who was doing immunology work. And when he, one of the things that he discovered, interleukin-2, was the things that, you know, he tried for solid tumors. Interleukin-2, just to give you a background, is one of the natural occurring chemicals that your body makes when you have an infection. And he thought if you can use enormous amounts of that and give it to patients, perhaps their immune system would be stimulated enough to fight cancer. Well, he tried this on all sorts of cancer, and eventually he found that melanoma was one of them that responded. So when I was a research fellow there, we gave interleukin-2 to everything and everybody, and unfortunately it's still, you know, again, because it was a very early, you know, early trial, that we've only found that selected people had a response. But actually those people taught us a few things. So just to give you an example, the very first patient who responded to interleukin-2 was actually very young, 30-something-year-old woman who was diagnosed with stage 4 metastatic melanoma. She actually worked for the Navy, and so when she found that out, the Navy stamped on her official papers, death imminent, and told her to retire. So of course, being a young woman, she was like, I'm not going to do this. So she went and basically went through all sorts of clinical trials. So when she started looking at my boss's clinical trial there, she said, you know, what have I got to lose? So she ended up actually, she was the 60th person to try this. Nobody else had responded. And my boss was actually at that time almost ready to give up. But there's somebody else here who's like willing to try, be the 60th person. And lo and behold, she responded. Now, at that time, we didn't know how to give this drug. I mean, again, you're like, trying something new for the first time. So she ended up having lots of toxicity. She ended up having it intubated and all sorts of things. We chip her teeth because during the intubation process. But in the long run, she ended up having response. And that actually led my boss, as well as a whole bunch of other immunotherapy researchers, to not give up. Because honestly, they were ready to give up. And again, that was in the 80s. And through the 90s, when I was working there, there was not that much progress. But little improvements over the years eventually bring a lot of things together. And over the past 5-10 years, there's been enormous progress for this. And it is really, as you were mentioning, personalized medicine is a great example of personalized medicine, because none of these drugs kill the tumor at all. Their main purpose is to stimulate the immune system, to have your own immune system fight cancer. Actually, so now among the many drugs that are now FDA approved, for instance, the one that most people have heard of somewhat is the one President Carter received for his metastatic melanoma. It's an immunotherapy drug. It stimulates his immune system to fight off cancer. So it's the very essence of personalized medicine, because his own body did all that. And most importantly, once your body got trained to fight off cancer, it stays with you forever. It's like when you had a vaccine as your child, your polio, you're still immune against polio. So the nice part about this is you only get your treatment once during that time. And once your immune system has been stimulated, then it's with you forever to fight off your cancer. So it's such a different approach to cancer. I think of it as rejuvenating your immune system to fight what it should be doing, which is to get rid of foreign objects. So technically cancer should not belong in you. And so technically that's really what the essence of immunotherapy is.
So here you have a surgeon who makes a living cutting things out, using your immune system to do the dirty work. How medicine changes. Absolutely amazing. Just a different knife, as John says. So, Trevor, you're another surgeon who has to worry about immunology because you do solid organ transplantation. And I wonder whether you'd opine about the issues of solid organ transplantation, particularly organ availability, because that is a major concern in the United States. And after you've done that, maybe perhaps give us a glimpse to the future and where we might be somewhere down the road in terms of being able to meet the demand for organ transplantation.
Sure. So I kind of how everybody was talking, solid organ transplantation has obviously changed quite a lot over the years. It's gone from a surgery that really never worked, and you can name the organ that they tried to transplant, to survivals now that are well into the 90 percentile for 5, 10. In the case of some organs, we really don't know how long they're going to last, and that's been due to advances in medication. So we've come a long way. But with sort of that success, our abilities to sort of, the people that we were willing to transplant has grown significantly, from really transplanting people with end-stage organ disease like kidney failure or liver failure, to treating things like liver cancer, to treating people with metabolic diseases that don't even have cirrhosis, so children that are born with metabolic errors in metabolism are transplant. So as we've sort of grown our indication for transplant, we've really, the real limiting problem we have now is really organ availability and organ donation. There's over tens of thousands of people that are currently listed for transplant. And for liver transplantation, it's approached over 15,000 people in the United States that are listed for liver transplant. And we do anywhere between 4,000 to 5,000 liver transplants a year in the United States. So it's a big issue of supply and demand. As we've gotten better at doing transplant, we've sort of expanded the donor pool that we're willing to use. So we use older donors, and as we've gotten better at doing the surgery, that we've been able to use these organs. One of the other sources that's becoming more and more popular, especially with kidney transplantation, is the idea of living donor transplantation. So the real benefit there is really to eliminate kind of that wait time, and some people can wait up to, for kidney transplant, it approaches 6 to 8 years in some areas waiting for a kidney. With living donation, we're able to actually transplant people when they're the healthiest, and where the surgeries really are elective. So somebody with end-stage liver disease, we can sort of optimize them so that we can do the procedure as safely as possible, minimize complications, and obviously, hopefully minimize their long-term, or maximize their long-term outcome. So that's really where the field is slowly moving into, is really living donation. And then there's some other sort of things kind of down the road with cellular transplantation, actually moving away, almost kind of what we were talking about with bone marrow transplant, moving away from actually transplanting an entire organ to transplanting either a part of an organ, which we do with liver transplants now, to actually transplanting the cells. So we've done a little bit of that. We have some experience with pancreas transplants, and actually doing auto transplants, so removing an entire pancreas from a person who's got chronic pancreatitis, isolating the cells that we know make insulin from that, and then doing an auto transplant into patients. So hopefully in the years to come, as we get better at hopefully eventually potentially manufacturing cells, that will move into more of a cellular-based therapy for expanding things from people with diabetes and chronic pancreatitis to people with liver failure, and actually be able to get away from actually solid organ transplants in some cases.
Yeah, the program that Trevor mentioned about islet cell auto transplantation is very unique, and we are really the only center in Virginia that's doing this for chronic pancreatitis. And there have been other places that have done it, but Trevor's colleague, Dr. Marlon Levy, is one of the leaders in the development of that technology, and we've done a number of procedures in the last few weeks, I think, last few months. And for people with chronic pancreatitis, it's a terribly debilitating, painful disease, and to be able to be relieved of that chronic pain and not suffer the consequences of having no insulin and therefore being an insulin-dependent diabetic. I mean, that's a huge restoration of quality of life, huge restoration. So Leland. Leland is a Renaissance man who has thought creatively about the discipline of radiation oncology, traditionally used, of course, in the treatment of cancer, but he's thought about other ways to use ionizing radiation to treat other very difficult conditions. But I want to ask him to talk about his main area of clinical care first, which is cancer treatment and novel approaches to use radiation or radioactive material to treat breast cancer, and then ask him to tell you a little bit about a very novel clinical trial that he started a number of months ago.
I'm a radiation oncologist, and that means, for the most part, using radiation to treat cancer. And that actually all dates back to Marie Curie. Soon after she found that pitchblende was this odd thing that sent off some kind of rays that killed stuff. Within a year or two, people were already using it to treat cancer. If you're ever in Paris, go to the Marie Curie Museum. It's a small museum that most people know nothing about, and it's absolutely fascinating. Her desk is there. Her husband's desk is there, you know, where she really did this work. But she started off, she wasn't a physician. She was a scientist, won the Nobel Prize twice. I mean, no one's ever done that, I don't believe, except her. But she, soon after she found this material, people started using it, and they used it to put radiation into cancers. And that happened already by 1900, within a couple of years of her. And we still do that. We've done it in much more sophisticated ways. We can tailor the treatment much more finely than we ever could in the past because of technological advances and new isotopes, so we can control how far the radiation can penetrate cells. And one thing we do a lot of it at VCU is treat breast cancer. Radiation, in some ways, rather than being restorative in this sense, is preservative. I mean, we look at it as organ preservation, so you don't have to have stuff cut out. It's kind of like, I've always thought it was like Dr. Bones in Star Trek, you know. You just hover this little device over something, and there it goes. You cured it. But for breast cancer, we, women will have a lumpectomy for the tumor, and then the traditional thing to do after that has been to treat the whole breast for several weeks daily. And if you live a long way away, that's very inconvenient and time-consuming. We now put radiation directly into the tumor. I'll show you this later. From your distance, you won't be able to see what's going on. But we put a device like this in the tumor, and then we expand it to the appropriate diameter, and then give radiation through this. VCU's become one of the pioneering places for shortening the course further. We're looking at ways to do this in 1, 2, 3 treatments. Now the standard was 1 week, is 5 days. And one thing we're doing that is happening at very few places in the country is treating women who've had breast cancer and had a lumpectomy, and then get years later another breast cancer in the same breast. And we can do this for them, and still it's breast preservation. So there are exciting things like that going on in my field. One thing that Dr. Strauss mentioned that we started doing recently here relates to Alzheimer's disease. And this goes back, I don't know, a decade ago. A friend of mine and I were talking at a meeting, and his father had Alzheimer's disease. And my wife's family, all the women in my wife's family have gotten Alzheimer's, so she's been scared about it her whole, ever since it started, as you can understand. And so I was talking to my friend at this meeting, and he told me his father had Alzheimer's, and I said, wow, my wife's sister, just a few years older than she, has it too, and her mom had it. And as we spoke, we realized that radiation had been used extensively, really. It's rare, but it had been used frequently to treat amyloidosis, which is the deposit of this protein that we call amyloid, in organs outside the brain, and it was very effective at low doses. And that's what Alzheimer's is. It's really deposit of amyloid in the brain. So we said, this radiation should work. Why don't we use radiation to treat, your dad and my sister-in-law? And this guy ran with it. He's at Beaumont Hospital in Detroit, and did a lot of great mouse research. And we found that if you give low doses of radiation to a mouse, there's a mouse model that has Alzheimer's. If you give it low doses of radiation, you greatly decrease amyloid deposits, and you improve its memory. It's pretty easy to do that with a mouse, because you put them in a maze and measure how much time it takes them to get through the maze. And the ones that got low-dose radiation got through the maze faster. I don't know if that translates precisely to humans, but after those studies, we said, okay, it's time. Let's do it in humans. So he's opening the study at William Beaumont Hospital in Detroit, and we've opened it here, and we have 3 people on it now. And I just saw the first patient I treated in follow-up last week, so it was really, really exciting. And she gave me reason to be excited. She said, and her daughter was there telling us the same story, that she could pick up a conversation again, and she couldn't do that so well. In other words, she'd be in a conversation room, she'd go to the restroom or something, and come back and say, okay, this is what we were talking about before. Let's continue that. And she could do that. She was remembering to take her medicines better. I hope this isn't just wishful thinking on the part of an excited patient and an excited doctor after one patient being treated. But we'll see. We're going to treat 30 patients and follow them with sophisticated neuropsych testing. So it's not going to be just guessing if they're improving. We have a very intense battery of tests that they all will have to go through. And that's where we are with this now. So this is new stuff, and it really happened at VCU, and we'll continue at Beaumont, and we'll have an answer in 2 or 3 years, I think.
Yeah. This is one of the marvels and conundrums of science. We know that radiation causes cancer. People who've been exposed to radiation have a higher risk of cancer, but it cures cancer. High-dose radiation to the brain causes cognitive impairment, and people who have been treated for brain cancer with high-dose radiation therapy generally suffer from many of the cognitive deficits that appear in patients with Alzheimer's. But here, low-dose radiation appears to be beneficial, probably because it activates a restorative response in the brain to clear these abnormal amyloid deposits. So using a physical force, if you will, radiation, a physical energy, to harness the restorative powers of the body, just like John and Giao are harnessing the restorative properties of the immune system to fight off cancer and potentially prevent autoimmune disease and organ rejection, perhaps, somewhere down the road. Fascinating, absolutely fascinating. So I'm going to ask our panel to pretend they're back in 1974 with Steve Austin, okay, after his accident, all right, he hasn't become bionic yet. What do you think the treatment would be in 2026?
Well, we would replace or regrow missing bits of bone and replace his joints for sure. We can actually regrow segments of long bones, and we are doing this already with patients who have trauma like Steve Austin. Unfortunately, the type of trauma he gets is all too common when people crash motorcycles and cars. So we're actually treating this almost every day now. So we would reassemble him. We would replace the parts. I couldn't replace his eye, but we would certainly replace the other parts and make him work again. I don't know if he would run faster, but we would certainly get him back to work.
And let me just comment on some science that is going on at VCU that I couldn't bring today because of the time span that we have. But we have people working in sensory neurophysiology, taste and smell in particular. And they have developed prosthetic devices that are implanted in the brain that can restore smell and taste to individuals who have been subjected to head trauma where the nervous connections have been disrupted. Fascinating, and particularly for individuals who are wounded warriors, and this is the population. And it's not perfect, but the fact that you can get somebody who is anosmic, they cannot smell anything, to smell, you know, common odors, or to taste. I mean, the lack of sensation, both smell and taste, is incredibly isolating. So this is a huge improvement in quality of life. So even though Steve, as an orthopedic surgeon, can't take care of some of the sensory things, we have other people who can. John.
Well, I'm going to go back to Kirk, or Bones in the tricorder. I think we'll have probably methods of being able to detect cancers preemptively, I would hope. That we would have, not necessarily going to the whole point of going nanobots and all these kinds of molecular machines, if you will, though that's a possibility. But I do think that we will have the ability to catch cancers when they are at their most vulnerable, before the immune system has not only tried and exhausted itself trying to treat the cancer, but to actually bring in the cavalry at the time that's very specific to the problem that's starting to develop. But I think let's get away from cancer. What about using it to slow the effects of aging? Why not use it to repair? Aging is essentially where we lose some of the regenerative properties of the cells, because every time it divides, it loses a starting point for the regenerative enzymes to completely and effectively replace or recopy the cell in a perfect way. Are there ways that we might be able to do that? Those, I think, are where we're going to be heading. Sort of a, rather than fix it after it's broken, why not doing ongoing maintenance like we should be doing for our cars, but we don't always do, right? But we should be doing that for our bodies in that same way. And I think we may have more effective tools to do that in the future.
The tune-up. Giao.
From the same standpoint, you know, as we know that as we get older, immune system, you know, does have some problems over time, and people can become more immunosuppressed over time. So there are researchers who are currently studying on there are different types of cells that actually are younger cells, younger lymphocytes, and then actually we can regenerate them in the lab. So perhaps in the future, you know, we can use some of our own younger cells and actually grow more of it outside of you and then reinfuse it back to you. But basically, there are different types of white blood cells. It's pretty fascinating.
Yeah, what Gao's referring to is when you went to get your flu shot, which I hope you did, and if you didn't, shame on you, they asked you whether you were over 65, and they supersized the dose. Because your immune system is less effective as you age, and what Giao just mentioned, the regeneration or rejuvenation, I should say, of the immune system is something that I believe, you know, with you, that represents a future. Trevor.
So I really don't know the
You don't remember? You weren't born yet.
So I don't know exactly what they replaced, but I think now, you know, transplant has gotten to the point where there's a real limiting thing is really rejection and trying to get your body to not recognize that whatever we've transplanted is foreign. So there's not really much now that we haven't at least tried to replace or transplant for solid organs. So, you know, most of it is pretty standardized: kidneys, livers, hearts, lungs, bowel, and now people have started to replace hands, face. So that's really the limiting thing, is if we can figure out how to trick our immune system enough to get it to accept whatever organ we've transplanted. We've figured out pretty much all of the technical things, other than maybe sort of nerve regeneration and that sort of stuff. But even that is coming along, that in time we'll be able to really replace anything. Hopefully in the future we'll be able to take our own cells and be able to generate organs that really are our own. and transplant those in time. I mean, that's probably decades away, but some of the research is already there in rodents and being able to develop sort of our own organs.
Trevor, do you think we might have third-party off-the-shelf, here's a vial of an organ, and let's transplant that?
Yeah, no, for sure. The cool thing is that hopefully someday we'll be able to take, say, a kidney and strip basically all of the cells out of the kidney except for the matrix of that kidney, and then repopulate it with someone's own progenitor cells and allow that sort of kidney on the matrix of an old kidney to regenerate itself and become a viable organ that we can transplant back into that patient. And then we've now eliminated all the problems we've had with tolerance and getting your body to accept it, because now it's itself. So we've eliminated, immunosuppression and all the complications that go along with that. So that's sort of the real future, but that could be 10, 20 years away. But there's been some really significant strides that have been done in that already. So it's exciting.
Leland.
I'm good about predictions, except when they're about the future. I don't know what to do with that. But with Steve Austin, I think he would have been even better if he'd had radiation. People that have traumatic injuries actually, get little pieces of bone that develop outside of a broken joint sometimes. And radiation at low doses, again, just like we're using in Alzheimer's, radiation at low doses is very effective at stopping that from occurring. For the future of radiation, I really have no great guess. Something very exciting is happening with radiation therapy and immunotherapy. It turns out that big single or a few large doses of radiation, given, say, over a few days only or one day, is sort of a vaccine. It makes your immune system more capable of recognizing an abnormal cell. I mean, cancers are kind of weird. They grow, and they're under the radar. They've hidden themselves from your immune system. Your immune system doesn't think they're abnormal. We've now learned that radiation can make your immune system recognize them, mess them up a little bit, and your immune system says, "Hey, that's not right, that's not me," and goes after it. We have a crazy name for that. It's called an abscopal response. You'll never hear that name for anything else. But we're given immunotherapy and radiation together, and that's, by the way, why Jimmy Carter's here, I believe. He had radiation, he had radiosurgery, we call it, high single doses to the tumors in his brain, and he got immunotherapy. And what is that, 2 years ago or 3 years ago, a man that just a decade ago had an incurable disease looks great. I mean, he's here, and he may be cured. There's some very exciting stuff.
Great. We're getting to the red zone here for time, and I'd like to thank the panel, but before we clap for them, I think we have time for a question or two. Am I looking for Brian, timekeeper? Great. We have time for a question or two. Yes.
Question in terms of organ transplant. Is there an upper age at which you are not likely to accept an organ from a donor?
No. And actually, I think is there as you age, you are less likely to accept an organ. I think it's actually the reverse, that we actually see patients that are older, their immune systems are actually a little bit weaker. It's the kids that we have the hardest time with, and those are the people, or those are the patients that really need the most immunosuppression, because their immune system's so amped up that they actually require the most. As you actually age, your immune system actually weakens. So the older patients, we actually run on less immunosuppression.
Trevor, I think there was also the converse question about age for donation. So if the donor, if the age of the donor.
No, we've gotten over time, not really, actually. I think it's what we usually say 70s, 80s, but we've used livers from donors in their 80s that work. So there's a lot more than just age that sort of goes into donor selection. Yeah, a lot of those organs will work. We've found.
There's a question way back at the back of the room.
The talk tonight has prompted me to think about a recent study, an article that was in the New England Journal of Medicine, I believe, that said that there is a age limit on human longevity of 115. Is that something that can be bridged in the future? Or do you even recognize it?
I mean, I'll take a crack at it. I think.
Why not?
Why not? I
70's the new 50.
70's the new 30 if we're talking 120. Come on. So I think we first have to understand aging better. We're still trying to find out what is the true biological basis for why there is this limitation. Right now, the catch-22 is I talked about that thing about the ends of the chromosomes that keep getting lost every time we renew a cell. Eventually, it starts crowding into parts of genes that you got to use, and when the cell finds that, it says, "Oh, I'm done," and to protect the organism, it dies. And when enough of that happens over enough of a lifetime, eventually you don't have enough cells to sustain, life and survive. When you try too hard, at least with what we know now, to correct that, now you may potentially even create a new monster. Now you've created something, if a cancer develops in it, you can't make it go away because now it is never going to die. And so now we have to find the way of, the body has a decent way of controlling that, maybe slowing aging. But if we can find some way of finding that good middle balance, I think we still need better understanding of why aging happens. And let's face it, we know just from family members and from our own experience, people age in different ways. People have aging in different organs at different rates. Why is that? And so aging is not just one monolithic issue. I think it is, again, an individualized kind of process for everyone. And understanding how that unique pattern of aging occurs in people is something we have to crack first before we start getting into the numbers game.
And if you haven't tried it, yogurt. You remember those? You remember those television ads with the Russians who have the longest longevity?
Exactly.
And it was the yogurt. There's no.
Right, yeah.
Yes.
Well, there may be a basis for that. Actually, if I can step aside, there is a basis for that. There is. And actually, one of the other things we need to learn about and talk about replacement therapy, it's good for the bones. But one of the biggest immune organs in our body that we haven't talked about tonight is actually the bacteria in your gut. All right? So Jamie Lee Curtis might actually have it right with Activia. Okay. It's not the whole answer, but we're now starting to look at I don't know if it's gone into the solid organ transplantation, but we're actually part of what's called the Microbiome Interest Group at VCU, national transplant centers that are looking at the effect of the antibiotics we use, how it changes the bacteria in our gut, whether or not that changes our ability of our immune system to function in a good way or in a problematic way. And so this is yet another thing. And the complexity of the genome and the genes in the bacterial things that we carry every day is 10 times more complex than in the cells we were born with. So that's another area which, symbiosis is another part of it. We have to live with our environment.
One more question here.
For the gentleman talking about Alzheimer's and radiation, have you used a proton unit at all due to the way it's detailed in its being?
No, but in this setting, I wouldn't be opposed to using protons. They wouldn't have at the moment, they wouldn't have a particular value. The protons are interesting because you can control where they deposit their maximum dose very, very well, better than you can with X-rays. Right now, in Alzheimer's studies, we're treating the whole brain because the patients that we've found so far have had rather diffuse disease, even though their memory problems are minor. They still, by the time we pick them up, they have disease all over in the brain. So because of that, we're trying to treat the whole brain. If someone said to me they wanted to treat protons to do this, would I think it was crazy? I'd say no, it's fine. It'd just be another way to do it, though. There wouldn't be a particular advantage in this setting.
Question here.
On a preventive basis, if we were to go to the Massey Research Center and have the gene scan, the body scan, and we were to find that we had evidence of cancer, of course, you wouldn't have it today, but you've had indications that you have the cancer cells in the body. Is there some way through the immune system that we could see that and treat that now instead of waiting for it to be cancer and evidence of cancer now?
Actually, that's what we do after our bone marrow transplants. We're introducing true gene sequencing. So a patient goes through, we actually, first thing we want to do is at the diagnosis, we want to understand what is the description of that cancer. Like those old cop shows, be on the lookout for, and they give the description. We want a BOLO, be on the lookout for the cancer, and we want to keep an eye out for that. And once we have what's called a molecular signature for that cancer is, we're going to look there, because it's too late to wait till, the biopsy is abnormal. That's too late. Or even if we can see what we call cytogenetics. Remember biology, all of those chromosomes lined up in the biology book. If we can see the changes there, that's too late. If we can see it even with something we call FISH, which is using special microscopy to identify it, that's too late. But if we can identify at the point of gene sequencing, then we're at that point where we're seeing a change. And we're actually doing that, or starting to do that now, where if someone with leukemia has a certain pattern and we see the hint of that first pattern, we tweak the immune system, either by taking them down off their immunosuppression to give their donor a chance to get in there and wake up and smell the coffee, or to actually bring in more cells from that donor's immune system to start bringing in the recruits, sending the cavalry over the hill, or even using medications, as Dr. Giao has talked about, to actually tweak the immune system to make the cancers more apparent or enhance the immune response. So we're doing that now. We're doing that in transplant. What we want to do is learn how to do that earlier in the process. Okay, and that's, I think, where you're going to. So we're working on it. We'll perfect it in transplant and export it backwards, probably.
Yeah, and I think in many heritable cancers, women, for example, who have mutations in the BRCA1 or BRCA2 gene, there are prophylactic procedures, prophylactic mastectomies, prophylactic removal of the fallopian tubes and ovaries where ovarian cancers arise. If someone has mutations that are associated with colon polyps that are likely to become malignant, frequent colonoscopies and removal of suspicious lesions. So there are some prophylactic approaches that you can begin when you've done the gene scan. But these are for hereditary cancers.
What if you can do it some of this earlier?
Oh yeah, no, I'm saying yes, and
Waiting for your
right, right.
There's a condition that's in your body that's just going to happen.
Yeah, absolutely, and for families, again, because of many of these are familiar, they're inherited. mutations that it is recommended strongly, although interestingly enough, many patients do not get this recommendation from their physician, that the potentially affected family members have a genetic analysis to know whether they are carriers of those mutations so that they can be either subjected to more routine screening and or a prophylactic procedure.
Actually, I have a good example for that. There's a heritable disease called multiple endocrine neoplasia syndrome, and there's a type that actually you can find the exact, there are multiple mutations in a particular gene, and for each family you can identify what particular gene, and based on prior experience you can almost identify what age somebody will get medullary thyroid cancer, for instance. So there are patients who have certain genes where we recommend the baby actually gets the thyroidectomy before they're 1 year old, because we know that they're going to get thyroid cancer by a certain age. So there are actually specific genes that are related, and it's amazing. It's a chart. You can look at what gene that you have and what age that it's been recommended for you to have that organ removed by then. But unfortunately, we don't know that much detail for most cancers, but for certain cancers such as that, we do know.
Great. Well, thank you very much. You've been a wonderful audience, and thanks my colleagues. Now I'd like to ask the tall one to come say a few words.
Took an orthopedic surgeon to show me how to do that. Folks, we've heard some analogies from the panel. So in honor of the World Series, I'm the closer. It's the bottom of the ninth. Cubs are winning. As chair of the MCV Foundation, I stand here tonight at my 8th Discovery Series, so proud of the work that takes place on our campus. So proud of these magnificent doctors. So proud of Jerry Strauss and what he's done for our School of Medicine. So proud of what the professional staff behind the doctors who make them all look good. Technology, nursing, all of the schools. We have a magnificent institution. And I want to thank you folks for welcoming us. Look at this crowd. This is the biggest crowd we've had. And it's only big because you don't want to quit. But I'm what's standing between you and drinks and dinner, so I know go but so far. But we are so proud. I'm proud to be chair of this board. It's a great honor. It's a great institution. We protect the assets. We raise money. We dole it out where it's needed. And we raise a lot more. So I want to thank you for welcoming us. I want to thank you for your consistent. How many folks have been here for all 8 of these? Raise your hands. How many have been here for 7? 7. It's incredible. I think it's really is impressive, and I thank you all for being here. And most importantly, I'm here to deliver great news. Jerry Strauss has signed on for life. We are really fortunate to have you as a family joining us. We have a great host committee who really, without the host committee, this wouldn't have happened. And this kind of loyalty would not have been sustained and sustainable. And we are taking the Discovery Series on the road. We're going to add other cities and bring other communities on board and do exactly what we're doing here. For those of you that have joined the inaugural club of the Discovery Society, thank you. It means a lot. It means that you're with us for the long haul. And for those of you that aren't members yet, I think you should join. I hope you will join. It's not only what you give, it's what you get. But I will tell you, it's worth it. We do great work. We have great product. We deliver great students to the medical community, not just in Virginia, but around the world. And it's something we're all extremely proud of. I think what's important about tonight is I'm looking at everybody from the side, and nobody wanted to get up. Usually you go to these things and people just want to get out. And I know you're hungry, and I know you're thirsty, and there's plenty to come, and it's good. And please save room for the cannoli. But when you leave here tonight, please go inside. You're going to be able to talk to deans, professors, staff members, development folks. Important to meet those development folks. Denise Lynch, Cheryl LaCroix, two very important people. If you would please just stand up, these ladies. Many of you know that they are very special at helping navigate, should you need navigation. It's a complicated process in a complicated place, and they are wonderful. They give 24/7, and we love both of you. Thank you. Thank you for what you do. But most importantly, it's about a great world-class medical center doing great things, and we'll continue to continue to do great things with an audience like this and a family like this that's expanding. So we'll see you at the next Discovery Series event. For those of you who remember this as a society, we'll see you at the Muscarelli. Good reason to join if you want to come. It's going to be a great party. And we know this group likes to party. So again, to our panel, you are wonderful. Thank you very much for another wonderful evening. Jerry, great job. We're adjourned. Thank you.